Good morning, everyone. My name is Lizzie. I am a nurse here in Baltimore City. I have worked in a lot of different spaces, inpatient and outpatient in the community, most of it harm reduction focused. And I currently work for the Maryland Department of Health Center for Harm Reduction Services. And so I'm doing a lot of statewide capacity building around clinical staff in wound care and non-clinical staff in wound care, especially in our syringe service programs who are doing a lot of heavy lifting and, the ones that are seeing people's skin and wounds the most. I'm just curious, with a raise of hands, how many people are clinical? Oh, look. How many people are non-clinical? It's a handful. Thanks for being here. Yeah, hopefully everything applies, and we welcome all of that because we know that even our non-clinical staff are doing a lot of first aid out in the field. So we want to really thank you all for doing things that feel or are out of your scope, but knowing that first aid is something that we can offer people. All right.
Hey everybody, I'm Kara Cohen. I see a lot of overlap from yesterday, so thanks for being here. I am the Associate Director of Project Home Street Medicine, so we do primary care for people experiencing homelessness in the streets of Philadelphia. I'm an adult gerontology NP. I don't currently have a wound certification. My wound experience primarily comes from working with the illustrious Lydia Williams, who you met yesterday, who's amazing, for the last 12 years. And then I've been working on my CWS, which Lydia told me I just really need to buckle down and finish. So hopefully this summer, maybe the next time you see me, I'll be a CWS. But currently I don't have a wound care certification, but we do have a lot of xylazine wounds in Philadelphia. Lyd?
Hey y'all, good morning. I'm Lydia Williams. I'm a family nurse practitioner. I work out of Philadelphia with Kara at Project Home, doing street medicine, office-based care, and home visits. I am a certified wound ostomy and continence nurse. I have been doing that for 15 years. And so I'm really excited to be here. Once again, thanks for all who were at our talk yesterday, specifically about xylazine wounds, for coming to hear more. We're gonna kind of get down into the details a little bit more. And we'll talk a little bit about xylazine wounds, but the take home that I want for you guys to get today is that xylazine wounds and other wounds in general, the specific care and how you care for them is not necessarily different. So I'm hoping today to give you guys a framework to be able to approach any wound you see, despite the etiology, and to be able to start treatment even if you're not sure exactly what to do. So I'm hoping we can do that today.
Sorry, a lot of switching back and forth. So I know, like I said, there was a lot of overlap yesterday. First of all, you guys were amazing yesterday. Lyd and I were saying it was one of the best crowds we've ever presented to, so thank you so much. Second of all, I wanted to clarify something that I said yesterday regarding xylazine and Narcan that does not respond to Narcan. And one of our friends from LA asked me a question just right before this started about do you still use Narcan? Just because I said something about putting water on somebody because the xylazine does not respond to Narcan. I really should have clarified, and I will in all the future presentations, so thank you too much for our friend to LA for asking this important question. You do Narcan first. You always Narcan first because it's a mixed thing. I'm going to see if we can maybe send out some kind of notification, and I apologize for being unclear. So why I said the water is because what we were seeing a lot when xylazine first came out is someone would give a dose of Narcan, it didn't respond. They'd give another dose, it didn't respond. People were giving 4, 5, 6 doses of Narcan, which ended up being really problematic, and the person would still not respond. So what I always do is I give a dose of Narcan. The sternal rubs usually don't necessarily work. I'll give up to 2. And then, it depends if they're breathing agonally or not. If someone is not breathing agonally, you can always put them in a left-sided rescue position and kind of let them sleep it off if they're in a safe area. So it does depend. But yes, always use Narcan. So I'm really sorry if I was unclear about that because most of the time, the xylazine is not pure. There will be fentanyl in it too. So thank you so much again for that question. And sorry for the confusion.
right, so we're gonna blow through this kind of like briefly, okay? Can I? Yeah. Okay. I need to. Can we put it? Yeah. Okay. So here's the skin, right? Really important to understand this when it comes into describing wounds and like what's in it and how deep the injury is. Understanding the layers of the skin. So you've got the epidermis, which is your top layer, and there's 4 to 5 layers in there. The epidermis regenerates new epithelial cells, which help to like close wounds on the surface. And then the dermis has your deeper structures, your subcutaneous tissue, and then muscle underneath. And that'll be important when you start to think about classifying wounds, because you can understand that if you're seeing a subcutaneous tissue or other things, that the wound is much deeper. And then if you're not seeing those things, then more than likely it's a little bit more surface. So it's helpful in that way. We have none. I'd like to have some, to be honest. So here are the functions of the skin. The skin is the largest organ, and I don't feel like the skin gets enough love. Like, I've been doing this wound care work for a very long time. I cannot tell you how many times people are like, yeah, come in and tell us how to do wound care, all of it in 1 hour. And that's not gonna happen. It's a very vast topic. Your skin is the largest organ in the body, and it's the one that provides defense for almost everything. Before anything gets inside, it has to pass your skin. So we need to do a really good job of taking care of it and getting people to understand how important it is. So it protects your underlying structures, regulates your body temperature with sweat, insulates your body because there's fat underneath there. There's some immune function there because when your skin becomes injured, there are white blood cells that are like immediately released into the tissues to help to decrease bacteria. And then, of course, we know getting out and getting that sun, it helps to synthesize vitamin D. Okay, so acute wounds, right? So these are wounds, someone gets a cut, and generally an acute wound is something that's gonna heal in under 4 weeks, right? So the first process, you get a cut, your body automatically tries to provide hemostasis, right? So vasoconstriction of those small vessels in the dermis layer to control the bleeding. And then once that occurs and things start to clot, your body kind of naturally transitions into the inflammatory phase to help clean the wound. So that's when those white blood cells come in. Like one very common one to come in and during this phase is they're called macrophages, and they come in and they eat up bacteria, and that's the first line of defense against preventing infection, okay? And then they come in and they do their thing, and then you move on to the proliferative phase, which is where your body starts to develop a healthy scar to close the tissue. So these are wounds that are actually like healing from the inside out. This acute wound healing does not apply to like surgical wounds, right? Because they cut them and then they close them up. It's different healing. And then you go into the maturation or remodeling phase where the scar is gonna strengthen. But this is really important to remember and to like drive home to your patients. It's only going to go back to 80% of its original strength. So that means that anytime you have a wound somewhere, the skin is weaker than it was before. And every time you get a wound in that same place, it never goes back to the previous strength. So you start at 80. You get another wound there, it might be 60. You get another wound there, it might be 50, which is why sometimes I feel like those of us who worked in the hospital before would see patients who had things like pressure ulcers, it closed, and then they come back in the hospital and it opens right back up again. And that's because the skin is not as strong. You don't rebuild the tissue that's underneath, you rebuild scar tissue. So all of the other underlying structures are damaged and usually destroyed. Like there's no redeposition of the dermis and none of that. It just fills in with collagen, that's it. Okay, so it's not as strong, not as much padding, not as much cushion. So here's a picture of what happens. And then you can see all of the different things that come into play to provide hemostasis. So you got histamines that come in, there's little bacteria, your platelets are coming to clot. Then in the inflammatory phase, there's a phagocyte, fibrin is there to help with the red blood cells. And then you can see like there's redness and inflammation. And all of this helps the heat All of those things help so that your body's white blood cells can come in and work to get rid of the bacteria. Our bodies are always going to try to protect us and to try to close wounds as quickly as possible. And then you have a scab. And your fibroblasts are really important for collagen deposition. And then in chronic wounds, differently from that, there's an extended inflammatory phase. And yesterday, Kara talked about this a little bit when we were talking about xylazine wounds. And that extended inflammatory phase is the biggest reason why it's hard to close chronic wounds. So any wound that's open over the 4 weeks is much harder to close than an acute wound. So we really need to make sure that we're trying to close wounds as quickly as possible and to get people to understand that they need to do care immediately versus waiting and seek help immediately versus waiting, because once it goes into that chronic wound phase, it's much more difficult to heal, because commonly with chronic wounds, you'll have like these plateaus, and that is mostly because of biofilms, and I could do like a whole talk on biofilms. It's like a really complex thing with all this science and stuff. I'm not gonna do that. And then a lot of times, because it's stuck in the inflammatory phase, like we said, that when you go to the proliferative phase, that's when you're doing remodeling, rebuilding new blood cells, right? So if you're stuck in the inflammatory phase, then of course you're not going to be able to develop new vessels and tissue because you're stuck in one phase and your body can't progress. So there's lots of like, they call them MMPs, matrix metalloproteins, that are like in the wound bed that are stopping the wound from progressing. So the care has to really address aggressively tackling those and the biofilm. So it's really complex. And, oh, wait now.
There we go.
I was about to say now. Okay. I know this stuff, but I don't know if I can do it off the top of my head. I think this might be you guys, right? Okay. So we're going to get back to some of that other stuff, but they're going to like talk about some good stuff too. So we're going to let them get.
Okay, so I mentioned this again yesterday. A lot of this is piggybacking on some of the stuff that we said yesterday, basically about longitudinal care management. And when I'm talking about longitudinal care management, I think a lot of people are, when they're doing wound care, they're thinking about point-in-time wound care, which is like, I have a wound in front of me, and let me just do something immediately to this. And we're not thinking about what's happening tomorrow, what's happening next week, what's happening next month. Doing something in a point in time is good. Doing something with a fancy dressing in a point in time isn't really gonna like help that much. So you're always gonna wanna think about like longitudinally, which again is like why it's really important, and one of the reasons that I think everyone in this room is gonna be really successful at like treating wounds is because it's about like having like a relationship with the patient and being able to like follow up with all of the folks that we work with and find them and work on the care plan. So we're just going to talk about certain things like to consider about frequency of care, ease of care, what are the supplies you need, what are the supports that you have, what are the supports that your participants have, monitoring and measuring progress, and the goals of the patient. I'm sorry, I need my emotional support coffee. I'm sorry. Okay, thank you, sorry. So when building a plan of care, you want to consider how often does the care need to be done? How often does it need to be done? And you want to also think about that, like when you're talking with your folks, how often are they actually going to be able to change the dressing versus ideally be able to change the dressing? This is one of the things I was talking about for any of our folks who kind of like have an inpatient, outpatient setting. The 4 times a day, change the don't ever tell anyone, don't do it, right? Don't do it. Don't do anything 4 times a day. Really, don't do anything twice a day. Don't do it, right? I mean, like you might want to say if someone's like has a wound that's draining a lot and you don't have something very absorptive, they could change like the top layer if it's like there's a lot of strike through. But just like it's really hard for people to take pills 4 times a day. It's really hard to like, especially when you're managing other kinds of factors like that are, it's hard to change the dressing that often. So So how many times can they actually do it? And, ask our folks this. What do you think about, are you going to be able to do this 2 times a week, 3 times a week, every other day, versus ideally? I mean, we would love for our folks to be able to change their dressings every day, but if they don't have access to running water every day, or they don't have access to, safe places they can change this every day. And the reason we want to ask that is because it might lead you to select something like a triad versus a meta honey. I think Lyd is going to go into the dressings. Does anyone know what triad is? It's a little bit older. It's one of those zinc-based, it's like an autolytic debriding agent that's similar to meta honey, but it can stay on for up to 7 days. In our population, we find maybe about 3 days, versus meta honey, which creates a lot of drainage and can macerate the peri-wound skin. It's also an autolytic debrider, but that really should be done more daily. Or maybe you're choosing a foam, which is more absorbed. All these things that I'm mentioning, if you don't know what they are, Lyd's going to go over them in much better detail. So you might choose a foam dressing versus a Telfa dressing or an ABD dressing that doesn't absorb a lot. So if they're only, we do a lot of wound care for patients where we're aim for 3 days a week. 3 days a week, really doing it, versus telling them to do it daily and they do it never. And then you're also going to think about how easy it will be for a patient to perform care. So you're going to think about, where it's located on their body, trying to think of tips and tricks. Are they going to be able to do it themselves? Even if you don't think there's any way that they can do this dressing themselves, please educate the person on how to do it themselves so that they can tell somebody if they have an opportunity to get some assistance. So it's really important that people kind of understand what is happening for a lot of reasons, but especially longitudinally to make sure they're getting consistent care and to kind of help folks do some self-advocacy. I always think the first time I do wound care on somebody is the hardest. And then the next time, if Lyd goes to see somebody or my colleague Maura goes to see somebody, and then I go next, they'll be no, they do it like this. And I say, okay. So, people kind of figure out, because you're trying to secure things, you're trying to tape things, you're trying to do things. And so sometimes there might be tips or tricks to how people like that done. Choose supplies that can be obtained in large enough quantities to be consistent. So there are many wonderful wound care supplies, and there's stuff in Luxtra and stuff like Drawtex and things that we may not have heard of, and all of these things that are really expensive and can work really well in the right setting. But if you have one of them, again, point in time wound care is not going to do it. So you want to kind of say, if you're in a state, that's fortunate enough right now to have expanded Medicaid, we all need to have expanded Medicaid, but you definitely want to check if it's covered by the insurance. For some reason, this is something that I think a lot of the folks in our area don't even know, even when we're working with other nonprofits, we're did you know you can order supplies through people's insurance? And they're like, what? And we're yeah, they just send you everything you want, and it's expensive stuff, and they send it to you every month, and they're oh my gosh. So you can order supplies a lot of the time through people's insurance, and then you don't have to pay anything. Isn't that wonderful? And then can you give at least several days to the patient? I was talking with somebody yesterday who works in the ER, and I was talking about, if we're discharging someone from the ER, can you give 2 or 3 days of an inexpensive dressing to the patient? Just try to give them, I try to make sure someone has at least 2 to 3 days of whatever it is, because it might be a while until they can access care again. And, if they're changing the wound, maybe every 2 days, then giving them 2 to 3 days of supplies actually would stretch them out about a week, which would give people opportunity to A, see some wound progression, and B, find somewhere where they can get consistent help. The thing that I put in bold here is there is no specialty dressing that can be given for a single application that will be more effective than consistent ongoing wound care, even with more conservative basic dressing. So if you have something like an Luxtra or a Hydrofera or something like that, and you have one, it's not going to close the wound. I really wish they made magic wound supplies that close them in one application, but it does not happen. So sometimes this comes up a lot more because people really like to donate stuff, and we get all these, we're like, what's this? So kind of what I was saying yesterday, A, don't use a dressing if you don't know what it does. Like if you really, I mean, if it's not something that someone that does know what it does has ordered, please don't put it on a wound, because you don't know what it's going to do. And two, it's not really going to be that helpful to say, oh, I have, again, this really nice piece of like Inluxtra or whatever, and you're putting it on, and then the person can't replicate it. So you'd be better off giving some Telfa, you know, some Triad or some foam or something that you could give more quantities of. When we talk about different kinds of supports, here are all the things to consider. There's probably even more of these, but these are just some of the ones that I mentioned. Does the person have any friends or family who can assist? So consider in the care plan. You might want to talk about, you know, if they're staying in some kind of encampment, sometimes there's someone in the encampment who really, you know, helps out with the wound cares, especially if it's like something that people can't wrap or whatever. So, you know, think about that. Think about leaving that person gloves and hand sanitizers and stuff like that. Do they have access to running water? If they don't, you know, try to provide some bottled water and saline, and then in that way we can avoid the iodine and peroxide baths that people like to do to their wounds sometimes that we know is cytotoxic. Do they have the ability to store supplies? So you can order, a lot of times, like I said, the supplies, but do they have a place to store them? If they're staying in a shelter, can they keep a box there? That's really, really helpful if they can, and it gives the person a lot more like agency and autonomy and ability to kind of manage their own wounds. And if they don't have the ability to store supplies, do you have the ability to store supplies? And can you bring out like little bits for the folks? We kind of got into a little challenge with this where we're all being buried in our office like the cask of Amontillado. Like it's just like boxes and boxes of like wound care supplies. So we kind of dug ourselves a little hole. But if you have a nice storage closet somewhere, maybe you can do it better. I know, Lyd is like, it's a mess in there. Do they have access to watertight storage? Our nurse Hillary, who's in the back, came up with like the brilliant idea of like providing Ziploc bags. So we just have like gallon Ziploc bags, and that's what we give people wound care supplies in, so that, you know, if it rains a little bit or if, you know, there's some kind of moisture, that the wound care supplies stay dry. And then what are your local resources? Is there any kind of like skilled nursing agencies or any local wound clinics of people that kind of, you know, have been trained that can support ongoing care? Because as much as we would like to, we can't see folks, you know, every single time they need a wound change. Our team only has 4 people on it for all of Philadelphia. So, and we all, only one or two of us work a day. So we definitely have to, you know, try to figure out other supports to work with. When we're managing and wounds and monitoring progress, this is again important for longitudinal wound management. So just like I keep on like being like a broken record, but one of the things we'd really like you to take away is it's not just point in time. It's like what's happening with the wound, what's happening with the progress. Because as Lydia was talking about before, and I'm sure we'll talk about it again, it's going to help us figure out like, is this working? Do we need to refer? And if we're just always looking at it as a point in time, we don't know. So measuring, you know, get yourself some of those like paper measuring tapes. I think they cost like 5 cents from McKesson or something like that. And they're disposable, so they're not infectious. That you can, you know, measure the wounds, be writing that down somewhere so you can share the information. I take a lot of pictures on my phone. All of the pictures that we have in here today are folks that have given us permission for like learning purposes. They want people to like learn from their experiences. So all the pictures on my phone, I don't peep people's faces in them. I always ask permission to take them. And then if I ever am going to share them, I ask permission to. But for mostly, it's just for like my purposes and for their purposes. I do a lot of like collage photos where I show like before and after or like weekly progression. Because I think one of the things with chronic wounds is sometimes people just have this sense that it's never going to heal, so why bother? But when you can show someone that there is improvement that they might not notice from day to day, but they can see it in the picture, you really see a lot of people just getting really excited and stepping up their wound care. You're just going to check on like the frequency of like looking at the wounds. So again, just sort of not wrapping them and leaving them there, but checking in on them and making sure we're like watching for changes. Evaluating if the products are working. Wounds are dynamic; they change a lot. So what works this week and the next week, we might find that it doesn't work. We have a couple of people that we work with in our clinic where we sometimes see our street medicine folks where first we're doing this guy's wound, and it's like completely dry, and it has like all of this like Eshgar stuff to it. So we're like, okay, we're using Meta Honey, and then we use the Meta Honey, and then 2 weeks later, now all of the slough is gone, but now it's macerated. So it's like, oh, okay, well now we're using Hydrofera, and then like the peri wound area gets dry, so now we're using like A&D. So you kind of have to like reassess, and that's okay. It's okay to do that, to reevaluate, and even in the same person, even in the same wound, the needs are going to change. And has the patient been able to perform the suggested care suggested care plan, or have they had to mix and match care? We find this happens a lot, especially if there ever becomes a point in your city where there's just like everyone has wounds and they're scrambling around and like all different people are like trying to help, that people will be put in all kinds of random things. So maybe they're coming to us and we're doing like Triad and Telfa, and then someone else is doing Xeroform, and someone else is doing, you don't really know if anything's like working that way, and it's really hard. So if someone does have the ability to order supplies, then you can tell them to bring those supplies to the wound clinic or wherever they're going and ask that the person uses that. But even if they're not able to do that and they had to mix and match care, just to kind of know that is more helpful. And then you can also ask them, like, do they have a preferred method between the different things that they're using? Always we're keeping in mind the goals of the patient. And what is the goals of the patient? The goals for them might not be the goals for me. Not all of them necessarily want to like close the wound. Maybe they just want to like reduce the risk of infection. Like maybe some of them are like, I just feel like I'm going to have this wound, or I'm not going to stop injecting in it because I don't want wounds like, I don't want to like get a giant wound on other parts of my body. So maybe it's just to get it smaller to reduce the risk of infection. People are typically like very scared of limb loss. So is that something that they're scared of? What do they want to work on? And then, kind of be reintroducing that as we're like longitudinally performing care, and always keeping, the patient's goals at the center of the plan of care, because it's their plan of care. I always kind of say to our patients, like, we're a team, but you're the captain. So like, it doesn't really matter if I come up with like this idea that I think is really awesome. If you don't like it, we're not going to do it because it's not going to work, Okay.
All right, patient-centered approach, which we've already been talking about. So I just wanted to give a little bit of back up a little bit. So when Lydia and Kara and I were trying to decide like what to discuss, it was really that we're needing to discuss the basics, right? We're needing for everyone to know kind of how a healing process works and the basics approach, so we're not overwhelming people and they're turned off by providing care, which is what we're doing today. All right. So I put this slide in because I wanted to say like how we usually offer, which is kind of backing off of what Kara had said. And this is not from a paper, this is just from my experience, is the usual when we're doing outpatient community-based wound care is we have a varying amount of inconsistent supplies, right? Some people are buying wound care kits. Not a lot of our, but some of our SSPs here in Maryland, syringe service programs, they're trying to do their best, right? And then they have a website that says, okay, here's a wound care kit. Well, the wound care kit is like 2 Band-Aids, 4 different types of ointment, and then nothing really else of substance. So trying to use a critical eye on what we're actually giving out. We have a lot of clinical staff that's not trained or certified in wound care, which is fine, but that ends up being like a deterrent because they're like, well, I'm not certified, I'm not gonna even go near a wound, right? And just trying to see what we can do and connect them to care. Inconsistent clinical staff in community-based settings, so we all know that, right? Where a lot of places are short-staffed. The clinical staff might be in a certain area only 1 day a week or a few hours a week, which obviously limits the amount of wound care that can be done with a trained eye. And then non-clinical staff, like I said earlier, wanting to provide more hands-on care or first aid, just basic, like maybe helping someone rinse something, but because they're not trained, they're being told, don't even think about it. So when we're talking about a patient-centered approach to wound care services, Kind of like Kara said, we're consistently offering supplies and services, and that we're reliably able to provide those services. So it's no good, right, if we say Tuesdays are wound days from 1 to 3, and then it's like, oh, actually they got pulled in this direction. I know I have a friend in the room that is constantly being pulled in a million directions at HCH, and therefore it's like, how much wound care can we actually provide today? A lot of these infographics, I know that we even struggled to find ones, and you all might have as well, of what is a useful handout that, you know, can work for low literacy or low health literacy, both of those combined, with clear photos and pictures for the handouts. Really not only having robust supplies of the basic supplies, like Kara was saying, but also making sure that maybe they're clearly labeled so people know, okay, this is an ABD pad, or this is what they mean when they say a gauze sponge or something like that. And how to use them, right? That's really important, is to know how to use the products, whether they're basic wound care products or whether they're a little bit more advanced. Like Kara was saying, hands off. So maybe someone doesn't want you to touch them, you know, but they're willing to talk about what's going on with their skin. So if there are resources, you know, maybe you do have handouts. Maybe there's a video that you love that you can play for them or send them a link to their phone. Handouts, supplies, and then if they are willing to do hands-on care, right, like Kara was saying, educate them, make sure that they're participating, even if they're not going to be able to do it themselves, that they kind of understand what the rhythm is to changing, and what to look for. So educating our clinical staff, right? Taking the time to kind of see where the gaps in knowledge are. That's been a huge thing that I've been working on, is just trying to see what do you have for your particular setting and how can we fill in those gaps. And then with non-clinical staff, maybe they are able just to go over what the basics are for cleaning and what supplies they have, right? So making sure that they're trained in what services the clinical staff is providing so they can, you know, properly market it to our people. And then, of course, all the other things that fill in the gap, right? So making sure that we're addressing everything besides just what's going on in that one particular area, and knowing that we have to take care of our whole body to make sure that things heal properly, and that the social determinants of health. Oop. Now I broke it. Okay. Oh yeah, does anyone have any questions right now? Pretty basic stuff. Okay.
The iodine bath, you said was cytotoxic, but we have like the patients with like just really dirty hands that like just washing it with soap and water, not getting out like all the dirt. So,
Yeah.
Hi, my name's Lisa. Hi, we would use like an iodine bath for like patients with like just really dirty hands that soap and water wasn't getting. But you said it was cytotoxic.
So I'll clarify. I mean, iodine, of course, is great, like before surgery to cleanse, they use. Iodine is okay on intact skin. As long as the skin is intact and it's not an open wound, I use iodine for people who have trench foot. I love it. It helps to kind of dry things up. I was talking to someone yesterday who was talking about using iodine on people who have like frostbite, and especially like if there's like no wounds around it that are draining, that's appropriate. On a person who's non-mobile and they have a dry SR cap on their heel, that's appropriate. And we'll talk about that a little bit later. So it is appropriate on intact skin for the different uses you may use it for, just not for cleansing an open wound. Thanks for asking that.
Yeah, just to add, like what Lydia is saying, when I was kind of talking about the iodine baths, I think folks assume that like the wounds are always infected. And, you know, when we were, what was that stuff that our moms used to put on us? Bactine? I don't know, whatever it was. And it like stung, and we're like, if it's burning, it works. You know what I mean? And then if it's fizzing, that means it works. So I think like a lot of, the peroxide, like our folks love to pour stuff on the wounds and then it all bubbles up and they're like, this is great. It's like killing all the germs. And, you know, the thing about when I'm talking about like cytotoxic, for people that haven't used that or heard that word before, I'm talking about killing the healthy granulation tissue. I kind of like explain to people that like the wounds they almost look like a little fuzzy, right? Like kind of like pink and fuzzy when they're healing. And I'm like, have y'all seen that? And they're like, oh yeah. And I was like, okay, well like the iodine and the peroxide will like kill that. So,
Good pictures of that type of stuff coming up. I have some good pictures of like being able to kind of determine what's healthy and what's not. So we'll get there for sure.
thank you. That was a great question. Is there?
Yeah, I had a question about like skin strength after healing that you were talking about, the 80%. Is that something that persists over time or over the course of like months to years? If that wound remains, if that like scar remains intact, is that skin eventually going to recover more than 80%?
Never.
The response was never.
And not like that, right? Never. No, never. So, and also it, never, yeah, no. But when it closes, right, immediately, it's not at 80 at that moment, right? So even if there's new tissue over top of it, it takes time even for it to get to 80. So the skin closes and they'll be like, you ever hear people like, it was closed and it's opening right back up. And that's because the skin is not really strong at all because it just closed. So it takes time even for it to get to 80. It's really like crazy, right? Anyone else? Yeah.
Hello. Not to go over every product that's out there, but I use chlorhexidine wipes to like either initial, a lot of times unexpose the wound to clean it up or to clean the area. Yeah, I was just wondering what your input is on that as.
What's the other substance, y'all? PHMB? I think it's PHMB. I can't think of what it's poly. I think I have it on one of the slides maybe. I think that I'm not sure about whether the, what is it called again? Chlorhexidine, thank you. Ooh, thanks, brain. I'm not sure if it's cytotoxic, to be honest with you. And when I usually don't know, I will steer away from using it, right? Especially, like if I don't know if something's gonna hurt the wound, I would just use saline. Or really, to be honest with you, there isn't a lot of data to support that cleaning a wound with saline is actually better than washing it in the shower. So regular soap and water, I love it, to be honest, it's great. Cleans the skin around it. The soap is like a surfactant to help loosen things up. It's great. Yeah.
So we're recording this session, that's why we don't like.
It's just using tools in front of me. But the quick search, there's a couple studies that show that chlorhexidine is pretty cytotoxic to direct open wounds, like three minutes of exposure to chlorhexidine. Also, I just want to put a small plug. If anyone uses NextGen, the NextGen mobile app is actually great, and you can take pictures. It like securely puts it right into the patient's chart, which is really handy.
Thank you. We have NextGen, and we did not know that.
You should check the
We're
app
going
out.
to talk to you at the break, my friend.
It's amazing.
It's like a 45-step process to do it for us right now.
Yes, thank you. We don't like NextGen, but we might start liking it now.
Thank you. So cleaning the wound daily, you said that would be like ideal, but wasn't there research like you should kind of leave it so then like the cells are working its way? If you wash it too quickly, then it might wash the cells building.
So we're saying cleaning it daily if the dressings that you're using require a daily dressing change. My goal is always to not have someone change it daily. But if they have to change it daily, then cleansing it is the very first step before you do anything else.
Thank you.
Yeah, thank you.
Ordering it multiple times a day.
Correct.
Got it.
More than 2 times a day is excessive. And really, in the outpatient setting, is very unnecessary. In inpatient, it's different. You know, I feel like for legal reasons, they can't really just let a wound stay there all day necessarily. I can understand twice a day. But I feel like my colleagues who are working in hospitals, they have moved away from twice a day care. Most of the stuff is once a day. So twice a day is usually very unnecessary, and 4 times a day, never do it.
Yeah, because I with the things, if we're not giving people something they can like reasonably keep up with, like the 4 times a day, like it's just so disparaging. It's like one of those things like, I'm never going to be able to do 4 times a day. Better leave it on for 3 months. You know what I mean? And then we're not really getting that. So it's just sort of like, we have to be picking things that are like completely, you know, reasonable for folks. And I think when we are choosing dressings, like running it by people and say, is this something you think you can do? Like, do you feel like you'd be able to do it? How much do you feel like you'd reasonably be able to do it? And when we're talking about like care settings, this will be kind of some of the things that we talk about, because it's not just, can you physically change the wound or do you have the supplies? There's a lot of other things. This will actually like segue nicely into, you know, a lot of the other things that factor into how often we can change wounds. Is there any other questions? You guys are coming up with good questions. We got a lot of stuff. We're going to kind of take little like pauses like this throughout the session, so we're not, so you don't have to hold all your questions for 4 hours and then ask them all in 15 minutes. Okay.
Hey there. I was just wondering, as we were talking about like iodine, chlorhexidine, soap and water, I've often had like a spray bottle that says like dermal wound cleanser, non-cytotoxic. Is this like helpful when you don't have soap and water? Is it better than soap and water? Is it just like marketed special water?
It's not. Usually dermal wound cleansers, most of the dermal wound cleansers even that you buy at CVS, or they are non-cytotoxic, and they also have, it's not just water, although, you know, we buy lots of products now, and I'm like, is this really Tide or is this the generic? So they do have like surfactants in them to help loosen up the drainage as well as like necrotic tissue. So dermal wound cleansers are great. Hang tight, y'all. We're going to learn all of this. It's coming up.
Okay, so now we're going to talk about care settings. How many of y'all work in brick and mortar sites? How many of y'all work in street medicine sites? All right, so we got a lot of, and I always like to poll, so I'm like, sorry, I was a nurse. How many of y'all are nurses? Okay, I'm happy to have everyone here. Like I said, I do street medicine, and then I have 1 day a week in the community. I do street medicine, and then I have 1 day a week where all of our providers have these landing sites. So Lydia has a couple days a week where she is in like a brick and mortar clinic, but a lot of our folks overlap. Like the street medicine folks will come to see Lydia in the clinic. I am at a different site, so the folks that can't go to that site will come to my site. So that is nice when we're able to do that. We work in primarily doing a lot of wound care on street medicine in Kensington, which I'm not sure if you have like kind of heard a little bit about Kensington, affectionately termed like the Walmart of heroin. That was a fun thing they called it. The largest open air drug market in the Northeast was like another really like affectionate title. So it's gotten a little wild there, and especially in the last couple years. I started doing street medicine in Kensington area in 2017, and I think it's gotten a lot more like dangerous to be around, especially sometimes some of the wounds are really complicated and large, and it takes like maybe half an hour, 45 minutes to do really good wound care. So the first thing you kind of want to do when you're looking to do wound care is like check the area, and is it safe for the patient and the wound care and provider to remain in the space for an extended period of time. So sometimes there's a really like one of the busiest hubs in Philadelphia and Kensington is Kensington and Allegheny. I won't do wound care there, even though there's a lot of people. If I find somebody, I'll move them. Even if I'm going to do it in the street, I'll move them a couple blocks away, because there's like usually like anywhere from 30 to 100 people, and it can change really rapidly depending on if they're giving out samples. So I've definitely been in a situation where I have people like hovering over me and coming up behind me and all of that. The other thing is that a lot of like paraphernalia. And I think like, you know, if anyone heard Monique Taylor talk, who's our wonderful certified peer specialist, and she was talking about when the drugs change, the people change. And I think when I first started doing street medicine, a lot of people would like put away their works and they would stop using in the middle of doing wound care. or receiving any kind of medical treatment. And I think now they're just sort of like not able to stop. So there's a lot of times that I'm doing wound care on people, like, and they just start injecting while I'm doing it, or they have like the uncapped needle behind their ear, or they're like, holding a crack pipe, or they're selling drugs, or they're doing things like that. And then everything is kind of happening behind. And so again, that's just something you kind of want to, I think about. There's never these like black and white issues, but to talk about with your team, about, do you feel safe to be in an area for an extended period of time? Talk about having a code word. If I'm not mistaken, I think in LA, do you guys have like a pen, like you do like a yellow highlighter, red pen or something like that? We do. We need to cancel lunch. So what we have this kind of code where if someone feels like, if I am talking to Lydia and I think Lydia might be in a situation, I say, Lydia, do you need to cancel lunch? And she'll say, if she doesn't need help and she's fine, she says no, and that means she doesn't need any help. And if she does need to cancel lunch, that means yes, and we all kind of pack up, okay, we're like, we gotta go. So that's something that we do, or it's something I can initiate too, and I'll be like, y'all, I think I need to cancel lunch, or they're like, oh, okay, all right, let's go. So those are kinds of things to do, like in terms of safety and, working with your partners to make sure they have a 360 view. I started doing outreach when I was like 22, so I started like in 2002. I did outreach in Boston, so I had a lot of experience doing it. And I got assaulted a couple years ago when I was actually with like 3 of my male partners because I was doing something with somebody and no one was watching my back. And I went to go like put something on someone's foot, and she like grabbed my hair and started like whipping my neck around. And I'm like in this very busy, looking back, it was very traumatic at the time, but like looking back on it, it must have looked like a cartoon because I'm probably like flailing around and this woman's like, but like the whole thing is you want to keep an eye on your partner at all times, especially like in wound care. I'm often kneeling, I'm often on my knees. I was in a position on my knees when that person grabbed my ponytail and I couldn't get out of that position. And she was like not trying to hurt me. She was just having I don't know if she was like on a drug or something, or she was having like a mental health episode. And thankfully she did let me go. But just even someone who's very, very experienced, it can happen. And being in a wound care position where you're lower than the person it's an extremely vulnerable position. So there's nothing wrong, it's kind of like being on an airplane, put your mask on first, make sure you're in a safe space, and know your surroundings, who's around, where you are, how you can get out. If you are in a really congested area, are there new faces of people you don't know? Are there new drug dealers of people who don't know you? A lot of the times we have pretty good relationships with the drug dealers, but sometimes they're like, what are you doing here? And we're like, okay, we're out. We'll progress on up to the next area. So these are kind of things to consider. You want to set up a clean space. We talked yesterday about wounds being, wounds are not clean and wounds are not sterile. Wounds are dirty, but you want to set up as clean of a space as possible. We carry a lot of those blue pads, those chucks around in our bag, and we set up a whole area. I put the bag on. When Lydia and I did home care, our nurse educator, Chris Bassone, oh man, I think she would we try to be so good, but she would roll over with some of the stuff that we have to do to set up our areas. I'm always sometimes Chris, I know you're somewhere watching me, please don't come in. Yeah, forgive me. Are you able to set up a table? Are you able to set up a chair? I wish I had a picture of it. There's this really cool thing, and it doesn't have to be this, but Google it and see if you can find something similar. It's called a cyclone seat, and it's like a little gardening seat, and it basically is like a disc. You ever see those collapsible cups that you pour? It's a chair, and it does that, and it's an adjustable stool, and it comes on straps, and it folds up into something about the size of a Frisbee that's about that thick. And that has been really great for us to carry around for outreach, that we can set that up. So it's called a cyclone seat. I think they sell something on Amazon. If you're not morally against Amazon, I think they have it there pretty cheaply. If not, you can support the small business cyclone. And something like that is really, really helpful. Try to keep in mind is, sometimes there's places that are more windy, or sometimes if you're doing something under a bridge, the dirt is falling on you. So just keep in mind your general area and try to pick the cleanest space possible. Privacy, that may or may not be possible. We have found a huge deterrent for people not getting their wounds cleaned is that they are just really afraid to show them to people. So is there like kind of like, can you set up sort of a private space with like a person barrier or like a table barrier or like a cloth barrier? Like, is there some way that you can set it up that the person doesn't have to show their wound to everybody? Also, there's so many nurses in the room, but I'm sure lots of you folks have seen stuff. I start out every single thing when they're like, this is going to be the worst wound you've ever seen. And I'll be like, sir, I'm a nurse. You're going to have to work really hard to shock me, you know? And just even if it is kind of like, ugh, I just have my poker face and I go, uh-huh. So, you know, we just want to make people feel as comfortable as possible. And, you know, the other thing is some of these wounds are on parts that people don't want to expose in public. Like I had someone have like a wound on their butt and we were like trying to figure out how we're setting up something in between the car doors with like a person's shield, and we figured it out. You want to have a plan for waste disposal, and that is like double bagging and biohazard bags. Like keep in mind that like, you know, a lot of our folks sometimes do have like, you know, they might have something infectious. The wound might be something infectious, or have like, they might have some kind of bacterial infection in it, but also some people are HIV positive and don't have a suppressed viral load. A lot of people have untreated Hep C. So it is infectious waste, and you don't just want to be like tossing it in a public trash can. So if the correct way, if you don't have like a Stericycle thing with you, is just to put the stuff in a bag and put it in another bag. And then let's say you didn't have 2 bags and you have like gauze, and you can like also kind of like put the gauze, you know, in your glove, take off the glove, change your gloves. If you're inside, do you have adequate ventilation? Some of the wounds have like a really, really strong odor. So just kind of keep that in mind, especially if you're borrowing a space. We had a community organization that let us use their space, and then they like kicked us out in 2 weeks because they said the smell was too bad. So just kind of like think about I know, I was like, oh well. You know, if you're inside, do you have some way to sort of ventilate? And the ability for take-home dressings. So again, the Ziploc bags, 2 to 3 days supplies, if possible. I don't know if Lyd has this somewhere. Is there something coming up on like infection control?
There is.
Okay. Lydia's rants are always so much more fun than mine, but like just, you have to change your gloves when you're doing this. Like you should never, ever, ever do, you know, a wound dressing where you're only using 1 pair of gloves. That's like immediately, you're setting yourself up for problems. Okay.
This one's kind of brief, but clinic settings is just making sure that, again, with capacity, right? Just making sure that can we actually provide it? How long is the wound care going to take? Do your other staff members know that you're going to be doing this thing and that it could roll over some time? So again, if you're offering services, try to make sure that you're setting actual time aside for those services. And yeah, there can be resistance in providing the wound care services due to time, also from what Kara was saying, due to privacy, and the fact that do you have those regular supplies? Did you order enough? And of course, the ordering of supplies is tedious, right? You're trying to keep an eye on the quantity of everything. Who's going to order it? Oh no, we ran out of this. What are we going to do? So clinic settings can just be challenging if it's not dedicated wound care space or wound care nurse or practitioner, and just trying to make sure that do we have a game plan in place to be able to consistently offer these services, consistently offer these supplies, and we're going to make time for it. All right.
Okay. I promise after this you'll kind of have a big break from me for a while. So the principles of medical ethics in wound care. Again, I know some of this might be a little bit repetition from yesterday. This is like so important. It's important not just for everyone in this room, the principles of medical ethics in wound care. It's important for everyone who's going to be teaching people. Our folks are so susceptible to medical tourism, and we're seeing a lot of it right now, and it's like, it's really gross, actually. It's like really unfortunate, and I think people are doing it in the name of, I don't know, like altruism or social justice or advocacy, but you know, we want to really think about, beneficence, which is do good, non-maleficence, which is do no harm, justice, which is ensuring fairness, and autonomy, which is ensuring that the patient has the ability to choose freely when they are able. How does this relate to wound care? It relates because people are going to be asking you to do things that maybe you don't feel so comfortable with, that you might cause harm, and that's what they prefer. And now we're stuck in a position where we want to be patient-centered, but it's also going against our clinical judgment. So how do you navigate this process? Sometimes people are going to ask you to do something, and maybe you think doing nothing is better. But so then you want to say, okay, I want to do no harm, right? But I also want to do good. And now is doing good doing something? Is doing good doing nothing? The one thing I can say, because I always say there's no right and there's no wrong. Like, if you don't know what you're doing, don't do it. And if you wouldn't do it, we kind of say in Pennsylvania, if you wouldn't, we have this main line where it's all these like rich, fancy people, and then there's like Center City. So if you wouldn't do it to some like rich, fancy person on the main line, don't do it to someone just because they live in a park. You're not helping anyone. This happens a lot with like dressings, that people don't know what they're doing. I think a lot about, I had one patient who had, she was muscle popping, and she had an abscess on her leg, and it started to like open up into a wound. And she was like, oh yeah, someone gave me this dressing. And like a provider had put like a hydrocolloid dressing on it, which I don't know if you know anything about hydrocolloids, but they sort of are like meant for like very like, Lydia, you want to explain a hydrocolloid better than me?
We'll talk about it.
Okay.
In a little bit, but they are occlusive, and they are generally contraindicated in any wound that is infected.
So it had gone from this like little tiny wound, and then I opened it up, and I took the dressing off, and it was like a giant hole in her leg, like down to like you could see like fascia. And that had happened in like 4 days. And I was like, ugh, like this is just someone that thought they were doing good. They're like, oh, like you have a wound, I have a dressing goes on wound. And now, you know what I mean? Like, but that really caused a lot of harm. I know we also were talking yesterday about like inappropriate uses of like Coban. Like if you are going to use Coban, you have to do a lot of like education with it. It's not wrong to use it, but you have to do education with it. And, I think people are just sometimes like afraid to kind of say like no, or they're afraid to admit that they don't know what a dressing does. Like a dressing is an order. Do you know what I mean? Like we wouldn't ever like prescribe a med that it's just kind of like, I've never worked with amiodarone before, but I hear it's for the heart. Cool. All right. Come back in 2 months. I know you don't see me regularly. Let me know how it goes. So it's an order. You wouldn't prescribe it to someone. You wouldn't give it to somebody if you didn't really know what it did. So we have to think of that in the same way, because like the skin is the largest organ. I think we want to be like looking for evidence-based, high-quality research. Like, where are we getting our resources from? Are we just getting it from like, I don't know, just like random people that are like talking online that don't really like know anything? Are we getting it from people who are certified? Are we getting it from things that are sort of like evidence-based? And I know like when we talk about xylazine wounds in specific, we're kind of always saying there's so much we don't know about xylazine, but there's a lot we know about wounds, so we really shouldn't be doing things that are not like evidence-based. So just, and I want you to kind of instill this in your students, as I'm sure you do too, that, we're not out there for ourselves. We're not out there, I mean, God, we take out some students. Everyone wants to lance an abscess under a bridge. Like, I feel like that's like the thing. It's like if they had like street medicine, like Girl Scout badges, everyone's like, I want my bridge lancing abscess thing. You know what I mean? Right? It's just like, no, like we're not out there to be like cool. Like our first thing is to provide the safest care. We are in Philadelphia. I can throw a rock and hit a major hospital that can provide safe care. So I'm not going to do like a whole bunch of like random crap to people and like perpetuate bad health care. Like the best thing we can do for our patients is build rapport, gain trust, establish a baseline for what excellent medical care is, and help people advocate that they need excellent medical care. So again, just to think about, thank you. I have my little soapbox. So again, to be thinking about all of this, and I just think about it all the time in terms of it. And sometimes we sometimes feel bad about we were talking yesterday about blindly giving dressings to people when we don't see their wounds. We will give the dry dressing, no harm package to people up to a point, but eventually I want to see their wounds, and I will tell somebody that. I'll do this for a little bit, but I'm going to need to see it. And actually in street medicine, for the most part, I ask to see someone's wound before I just give them stuff, because I'm not it's not that there's not places, there are places that will just give out wound supplies, but we're there to provide primary care services. So, I just kind of let people know, we're there to make sure you have the appropriate supplies. And I would say at least 50% of the time when someone takes off their dressing, it's not something I would have given them. So then we can give them the right thing, and I kind of just explain that to people. So sometimes, doing good is doing nothing. Sometimes it's not. I went through all of this. I'm so efficient, I didn't even know. Yeah, there's no one right answer, but we need to keep the core of medical ethics in our minds and at the forefront of care as we consider treatment options. And just, the last thing I think is how do you respect autonomy and promote justice while simultaneously upholding all of these principles? So lots of questions, not a lot of answers. Keep it in mind all the time, and it'll guide your care.
Balancing the safety and ethics component of it, you're talking about having to leave a situation when it's too dangerous to stay. What happens if you're in the middle of caring for a wound? What does that look like?
We will put the person in the car with us a lot of times. Let's go. We got to get out of here.
It is like a low key kidnapping. We're get in the back of the van, drive.
Yeah. So we will say to them listen, we got to go. We don't know what's going on. And sometimes really I feel the patients will be yeah, no, we need to move. That dealer is we need to go somewhere else. We can't be right here. So I think we're really good at assessing the scene, and our patients are really protective of us, wouldn't you say? Oh, yeah. So they're always oh no, we're not gonna go over there, we need to go somewhere else. So we don't run into it a lot, but there have been times where I feel we've been all right, listen, I'm gonna do this right here, we're just gonna wrap it up real quick, and then I'll try to catch you, let's meet a little bit later on this street here, and I'll try to see if I can see you again. So we will try to do it again, but sometimes we just have to do what we need to do at that moment. Covering it might be all we can do. I see a hand.
I just wanted to say on the flip side, there have been times when I felt oh my gosh, we're going to get arrested for doing what we're doing, because I was doing a dressing change on the middle of a very busy street, and all these business people were walking back and forth, and I didn't have all the stuff, and I had all this fluid, and I was what the hell am I going to do? And the person started injecting because it was so painful, and I thought we were going to get arrested for this person was injecting heroin, and I'm doing this highly infectious whatever. So that was another key thing of maybe move out of the direct sidewalk traffic. So
Yeah, I think definitely to try to find an area that's less traveled. Our nurse Hillary Miller here had a really interesting situation in the 30th Street station with some Amtrak police officers where we tried to. Sometimes if we find a space that we think is a little bit secluded and they don't, we just kind of have to stand our ground a little bit, which is what Hillary did, and kind of well, I'm in the middle of providing wound care. Now, the person was not injecting drugs at that time, so that was a little bit different. But if you're set up as well as possible to be bringing the chucks, to be padding your area, to be making sure that there's as little foot traffic as possible, to be bringing bleach wipes out and stuff, and through a harm reduction lens, then we kind of can push back a little bit more.
I just had a question. So this may be redundant to what you already discussed, but when we go out, we always go 2 people at a time. And I was just curious how you guys, because even with 2 of us, I often find that we get very quickly pulled, and so I was in a setting with my nurse and myself, and we were, I got in my first really, really unsafe situation, and she was across a parking lot dealing with someone in a wheelchair. And it was one of the patients who stood up and said to the other person, put the knife away, she's helping us. And they are, I think, mostly protective of us, but it was the first time that I realized 2 of us in a busy setting, even when we're trying to watch each other, it can escalate. It doesn't, and it hasn't in many years, but I'm just curious if it's only 2 of you guys and how many of you will go out, and if someone The other thing we're trying to implement is someone in the office sort of tracking us. But it doesn't, we tell them where we are, but it's not real time. So
Yeah.
we have a HIPAA safe texting where so we'll say, we're in the corner of X and Z. Now we're moving to, I don't know how, I'm just, for safety measures, I'm just wondering
Sure.
what else you could add.
The team is very small, so there's only 3 nurse practitioners and then our nurse Hillary. And we go out for that reason, for safety reasons, for like watching each other's back. We go out only with the outreach teams. So there are 2 outreach workers usually, right? And then sometimes there's 1, but our outreach workers are amazing. So they know, like they do not, very rarely, if we're in a situation with someone we do not know, will they move at all. They don't go anywhere. And if they do, they make sure that they can see us and that they can get to us quickly. So we are very careful about that. We are very careful about saying, like, if the outreach worker is going to go somewhere else, they're very careful about saying, even if they're watching, they'll say, hey, I'm getting ready to go over here and engage with so-and-so, but I'll be right back. Or if you need, you know what I mean? So we really communicate very well because Philly right now is very dangerous. So we have to watch it. Like there's shootings during the day all the time now. I mean, it's just really a hot mess. So yeah, it's definitely a challenge though, especially when you have, I feel like 2 clinical providers. We just want to like go do everything. We're, trying to be all efficient, right? We're like, all right, we got this person over here, that person there. I'm gonna go here, then you're gonna go here. Like we just want to try to knock everything out and get everybody. We don't want to lose anyone. We don't even want anyone to leave. So the idea of being like, we can't go over there because we need to stay with each other. You're like, no, I gotta go see him now. He's gonna leave. So yeah, it just takes some intentional work, and we had to really like have discussions about this, like how can we make our work more safe? And so we had to kind of like set some grounds with each other about what things we felt like we needed in order to do this work safely.
Yeah, and I think like this is such like an important question to what Lyd said about our outreach workers being really amazing is true. I was thinking about just another situation. Like a lot of times they'll advocate to make sure I don't even put myself in like a really dumb situation. Like there was this one gentleman, again, we had rolled up on K&A, which I always am like, I'm not going to pull up on K&A, and then I do. So we pulled up on K&A, and there's like, the thing about K&A is there'll be 30 people, and then it'll be like sample, and then there'll be like 100 people. So that kind of had happened, and then this one person's like lining up, and he's like, I want wound care. And then I was like, okay, you need to like come over here where it's a little bit less crowded. So he comes over here and he's like, okay, now I'm going to go over here. And he goes back behind like 15 people and there's like chairs all around. And he was like, okay, come here and do it. And I was just like, I can't do that over there because I didn't have a clear path out. And our outreach worker was like, hell no, we got to go. We can't be back in that little spot. And so she kind of advocated because, maybe I would be like a little softy and go back there. The other thing is if you can, if like Lyd is over there and I'm over here, it's better if you can kind of stand like this. And then that way, like I have her 360 and she has my 360. The other thing is, does anyone do red flag meetings? Anyone ever hear of them? I can't remember where the model is from. Kate, do you know where the model is from? The red flag meeting is something that anyone on your team can call. And it's basically if you have an event where someone on your team feels unsafe and you just sort of do like an immediate debrief of the thing. It's like not to blame somebody, right? It's just to sort of like express that you had something that felt unsafe. And there's a whole like, if you look it up online, I'm sure there's like a whole model, there's a form to follow about like what you do and to come up with like a plan. But it's sort of like a way to immediately address a safety need. And I think that's one of those things, like for something that happened with you, that would be something like you could call a red flag meeting and be like, this is what happened. And then you're kind of like, first of all, like expressing how you feel about it, like what sort of happened, and then what you need to change from the outcome of that. And those have been very effective because they're also like really efficient as opposed to like, let's put a pin in that and loop around and talk about it in the incident report. You know what I mean? Like, don't we love to put pins in things? But this is something that can be like very effectively addressed because like, the fact of the matter is, like, if we're not safe, like, I always think about this, like, if something happens to someone on our team, we don't have a street medicine team. You know what I mean? Because it just sort of, like, creates this whole problem. I got Hillary Miller in the back.
From the safety perspective, it's also really important anytime you're having someone coming out with your team to also make sure that they're aware of all the safety protocols that your team has. So whenever, unfortunately, anyone that comes out, any resident, attending student, any discipline, they have to listen to my voice for 30 minutes on a recorded PowerPoint, which, I'm sure they'll get to know me really well throughout that time, but it outlines all of these things that Kara and Lydia are talking about with the safety things, because we want to make sure, as Kara mentioned, that the safety is based on the person, we're all out and about all day, every day, but if the med student who, the first day feels that they're unsafe, then that's what we go off of, right? We're here to support everyone, and that's when we, they can even, anyone can call red flag, and that's kind of why we've been able to, establish our program and keep it moving, just to make sure that safety is, as Kara said, we couldn't do what we do if one of us is not, not feeling safe and supported. So just to, echo that we do that to make sure everyone that comes out on our team is also feeling safe as well.
Oh, okay. Just to kind of piggyback off that, we do street medicine in Los Angeles. So, Los Angeles is a different monster in itself. We do exactly what she says. It's going with the least uncomfortable. We have a lot of visitors, and we always make sure everybody's got a name tag like this for one, because a lot of times they know you're there to help if you're, wearing something like this. We don't let nobody ever walk away. Especially in if there's two of you guys should always have somebody that knows the streets and can guide you in the streets, right? You can always tell by the community too, the community that you're in, the encampments. The vibe of them will always tell you what's going on. If somebody approaches that's going wild or all that, first thing I do is look at everybody in the community, because if they're not reacting to that person, then most of the time you're okay. But remember, I'm from the streets. I grew up in the streets. I did everything in the streets, but I never trust the streets. When you start trusting the streets and you're too comfortable in the streets, you're already losing. And remember, the streets, every day's a new day. Don't ever think because you went there and everything was good and everything's all right, that it's going to be always okay, good, and all right. Never. Always remember that it's a new day and anything can happen in that day.
Thank you. That's very important. Thank you. So I think we'll do this last question, and then we'll move on, because I want you to get to the good wound stuff.
I have a comment and a question, but I come not from I'm street medicine, nurse practitioner. I've been in the job only less than 6 months. The group is actually somewhat new, and we already had small incidents, and I think that the best plan is to have a plan. To discuss about it. And I had to do a whole research, and I came out with a protocol, but it's just a lot of reading. But I think that would be my best advice. Plan something so you know what to do. There's something going on. So my question is that do you do a lot of, you mentioned something about lancing abscess. Do you do that? So far I haven't, because I feel that it's the street, I'm opening something, and I don't know, I'm just curious if you're going to talk about it or...
Well, I wasn't going to talk about it here in the wound care presentation. I was kind of saying it more I feel like that's the, what do you call it? What was the thing that Indiana Jones was looking for? It was just the thing that the Holy Grail, thank you. That's the Holy Grail of street medicine for a lot of these students and folks that come out, is they really want to see an abscess lance in the street. It's not that I've never done it. I just don't think it's best practice to do it. And it would really have to be a situation where I felt like the benefits would outweigh the risks, especially in an area, I don't live in a really rural area. I don't live where we are 5 miles from the nearest hospital. Our folks don't have to traipse 8 miles from the woods to go, they can go anywhere and pretty much walk to a hospital and get this done, or walk into a clinic and get this done. A clinic setting. So it would have to be a situation where I felt like the immediate needs of it outweighed the risks of doing it. So, I've been doing outreach been doing street medicine since 2017. I think I've lanced 3 abscesses outside. And and actually I did them in the SUV, which is kind of disgusting on its own, but better than being under the bridge in Kensington. I don't know. So, okay. All right. I'm going to stop talking.
All right. This seems really, really basic, but it's also something that seems to be overlooked, right? Is really building relationships with our community partners, whether it's big, establishments or institutions, or whether it's, just somebody down the road. So of course, communication, right? Communicate with your team, right? The discussions we were just having is like, what are the missing pieces for your team alone? Do you have enough staff members to do the things that you're wanting to do around wound care? So that way, when you are reaching out to network with other organizations, that you know what you're lacking or what your assets are that you can offer other places. So you guys can come up with a coordinated, plan for if a patient has this, then we can do this, right? So knowing the clinical pathways that your team can take based on the services that you can provide. A big thing that we've also been pushing towards is shadowing other people's spaces. That might be a shadow day, or that might just be kind of popping in there and saying, hey, I've seen your website, or I've seen you guys on Instagram. Like, what is the most up-to-date schedule of the services that you all are offering if my patient or people need this? Exchanging contact information, schedules, exchanging needs that you have. Like I said, this is very basic idea, but of course we are all busy. It takes time to reach out to other people. You sometimes don't get a direct answer. Sometimes it's best to go in person or have some staff member go there, just to get an idea of what the most up-to-date stuff is. And then also maybe, one place that you're working with, it's an opportunity for you all to train them on some things that you all are doing or that they could do before they are networking to you, or coordinating care with your services. Of course, go ahead.
So my philanthropy communications department, because I do a local outreach with SSPs, they put together a card, QR code, because where our van goes changes all the time, just based on where we can actually get parking, and we won't be hustled along by, law enforcement. You can't be here giving out needles. Whatever. So we'll move from place to place. Like 1 week we'll be in north of town, it just depends. So we upload all of our information where we're going to be to the website, and then our community partners, and even, we have a lot of our SSP participants that have cell phones. Mm-hmm. So they'll just scan the QR code, it goes right to our website, and then we always have up-to-date information on where we plan to be that day.
Yeah.
So it's kind of cool.
Yeah, that's really great. Yeah, that's a great way of doing it, so thanks for sharing. So when I was talking about training opportunities and shadowing spaces, let's not forget our inpatient or hospital-based care that maybe have never seen the community, right? And that doesn't mean they have to come, under a bridge and hang out with you for hours while you're doing wound care, but allowing them to, sit down and have their discussion of like, oh, this is what we're seeing on an inpatient side, whether you have peers that are in the inpatient side or not. But that was a training that I did with peers that are hospital-based peers, is that they were like, yes, we know there's things out in the community, especially like a harm reduction approach to those things, but they had never had the opportunity in being trained as a peer in the hospital setting to understand things outside of inpatient treatment or detox treatment to offer the patients. Funding opportunities, I'm battling this right now. Working for the Maryland Department of Health is just understanding there is a whole lot of funding opportunities that your organization or the state that you work in or the place that you're working in that they might have. So making sure that we are reaching out to the appropriate people or trying to get, a nice crowdsourcing of, hey, we have this funding opportunity. Is anyone needing supplies that we can order? Is there anyone that needs training that we can incorporate into this? So that is a part of networking too, is just being like, who has the money? What are you all applying for? And how can we tweak it to better serve more people? And then, of course, clinical needs. So I've worked in a lot of spaces where we've had very, very part-time clinical staff. Maybe they were full-time at the hospital and they were doing 3 hours on our mobile treatment van, right? Is just trying to talk to the places recruiting at, I don't know, I'm thinking nursing world, you know, coming into the hospital setting or coming into home care agencies and just being like, hey, I don't know if you all have ever experienced this, but this is a good opportunity that you can kind of expand your clinical knowledge and see healthcare delivered in another setting, which goes a long way. I know that I'm speaking to a crowd that I'm preaching to, that you all know, but we just need to diversify what people are doing, and I think that that everybody wants to be helping, and that this is a good opportunity to kind of just show them the work that we're all doing. All right. So when we are coordinating, right? Insurance is a huge one. Who takes what insurance? So, if you are offering services and you know that your services are limited to certain insurances, or reaching out to a wound care clinic and just being like, I just want to make sure, what do you take so I can make sure when I'm coordinating care or when I'm talking to a patient about, hey, there's this thing that I actually want to connect you to, that we know that insurance won't be an issue. Of course, supplies, like Kara already said, try to go through their insurance, just try to get supplies. Trying to encourage the settings that do have supplies stockpiled, that, you have a patient, maybe you'll write down they need like 3 rolls of gauze or Curlex. They need this, they need that. And that way somebody can get stocked. Discharge paperwork. So when I'm talking about this is just I was thinking of more community settings of making sure that, when people are discharged from a location like a hospital or emergency room settings, that either, if they still have it with them, that the clinic or community setting might be looking over those, but trying to make sure that when you have a patient that might be going into a hospital setting or emergency room setting, to be like, part of your discharge plan can involve me. Like I work at Healthcare for the Homeless, or I have a street-based team. So let them know that I'm your support on the outside. So that way, when they're trying to coordinate things, they're being realistic, and that we can come up with a plan, or maybe they even reach out to your, the team that you have on the community side. Heaven forbid we all communicate. And then, I'm trying to remember all the bullet points of why I put them there. So, right, we're trying to know the clinical pathways. So if we're needing to escalate care, what the plan is going to be. And then also maybe someone's moving towards healing, right? So maybe we're spacing them out on when you're seeing them in a community setting. But just letting them know, you're doing well, but here's kind of the timeline I'm envisioning, so they don't just drop off and be like, well, Lydia said I'm good to go, so, see you later, never, Referrals, right? We know that's huge. So this again goes back to coordinating care, but just knowing where you can refer to, staying up to date on those schedules and those referrals, so we're not losing patients because we're like, oh, that place closed in 2019, and they no longer do stuff. And of course, making sure we know what our patients can expect, right? So that's another really important part of networking, is I want to make sure that I'm not leading a patient in a false sense of direction, being like, oh, they're going to take care of you. They're going to give you, 3 bags of wound care supplies. You're going to be so good. And then it's like, that is not happening anymore, right? So really plugging into the places, trying to see in your staff if you guys can sit down and be like, all right, we haven't reconnected with this place in a while. Does anyone have time this week that they can call or stop by that place, give them our new number, or maybe we got a new nurse, a new peer, something like that, just introducing them. So not undervaluing just the importance of communication.
You broke it again.
Again.
All right, good. Yeah. I'm going to kind of blow through this slide because I want to get to all the nice meaty wound material that Lyd has. In terms of hospital inreach, this is a little bit what what Lizzie was talking about, we also kind of want to talk about like looking at our community partners in the hospital systems, which is something that I didn't realize how much of that we were going to be doing, identifying major hospital systems that are taking a lot of our folks for sometimes wound complications and reaching out to them. I was shocked that they actually wanted to hear from us. Like this wound stuff is like the first time that like literally like the doctors really wanted to talk to us. So I was like, ooh, we're going to leverage this. It was really cool. So we have identified interested hospitals and aligned individuals in the ERs or the inpatient units in our local hospitals. Hillary, our nurse, has done such an amazing job with identifying folks who have expressed interest in working with our population. We did something really interesting with Thomas Jefferson University Hospital, which is one of the major hospitals in Philadelphia, where we sort of have done like a little quid pro quo kind of like, we came up with like a wound regimen for them because one of the ED docs attendings was like, we know nothing about wound care. And we're like, we know. So we're like, we know about it. So we actually did like one of their talks for them. Lyd came. And me and Hillary, and we talked a little bit about like just basic wound care pathways and talked about things that they can do to kind of have them feel a little bit more empowered in the ER, that they're not just like sending people out and having like the revolving door. So we talked about educating the hospitals on discharging folks with 2 to 3 days of supplies, avoiding doing things like return daily to ER for dressing changes. We're like, no one wants that. The patients don't want it. You don't want it. We don't want it. So give them 2 to 3 days of supplies. You guys have money. Education on how to self-perform the care. So not just sending someone home with the wound care, but having them like teach the person. Signs and symptoms of when to return. Resources and instructions. I have this. Other than return to the ER daily for wound care. And this is also something that was really important, like educating people on avoiding scare tactic language, then this has really come up with the xylazine things, like such as like, you'll lose your leg if you don't stay. And this is really indifferent than informed consent. Sometimes I think that this is done under the guise of informed consent, but really it's like paternalistic medicine for people that like to say the words non-compliant patient. And we're like, you need this treatment. And then they go to the person's like, for whatever reason, they're not having their needs met. They want to leave. And they're like, well, if you want to walk again, if you want to have this limb again, you'll do this. And we're like, oh, I'm just informing them. But you can tell somebody, we're really concerned. We'd really love for you to stay. We're really proud of you for coming in. There is a risk that you could lose your limb if this infection progresses. However, if you stay, here are all the ways. If all someone hears about is they're going to lose their limb, I promise you, they're not only going to avoid the hospital, they're going to avoid every single healthcare provider and not show anyone the wound for months and months and months. So as community workers that are sort of like working on the front lines with our folks, I think we have, I just have been very surprised how receptive it is that hospitals are willing to listen and be educated. So we do have opportunity to do a lot of in-range there.
Oh, shucks. Here we go, y'all. Now, here we go. This is everyone's favorite part. What do I put on it? Tell me what dressing to use. All right. I'm never going to do that. We're always going to start with the basics. Okay. I think this was Lizzie's, but I'm just going to go over it real quick. Universal or standard precautions, right? So standard precautions apply to the care for all patients, irrespective of their disease state. So we're making it like everything that we touch is infectious, right? So we need to be mindful of that. Blood, body fluid, non-intact skin, and mucous membranes, okay? So this includes hand hygiene and personal protective equipment, with hand hygiene being the single most important to prevent transmission of disease. The single most important, especially for wounds, right? And so then we have the different transmission-based precautions, which I won't bore you with that. I think we've had enough of that during COVID. And then we're going to talk about clean technique because that's what we are using for wound care. Chris, I hope you're proud of me. Right? That was the home care, and she loved to talk about this. So it's non-sterile, right? So you're going to try to eliminate as many microorganisms as possible, but knowing that, it's not going to be sterile, and that's cool. So you want to prevent direct contamination of your materials and supplies. So like changing gloves after touching surfaces, between working with dirty materials. So briefly, I'm just gonna go over it, right? You got a wound, you clean your hands off with sanitizer, you put gloves on, you pull the old dressings off, you throw them in the trash. You take those gloves off, you sanitize, you put new gloves on. You clean the wound. There's 2 wounds, different legs. You clean one wound on that leg, you take those gloves off, you sanitize, you put new gloves on. You put a new pair of gloves on, you touch the dressing, you clean it, you take the gloves off. Every single time you are doing something with wound care and you're doing a new step, you need to be cleaning your hands, right? Because every time you don't, you are taking contaminants from the dirty dressings, or you're taking contaminants from the supplies used to clean the wound, and you're just putting them right back on there like, hey, come on back. So you have to be mindful of that, which is why getting set up is really good. Like I usually like to, in an ideal situation, like get my chuck out, take out maybe like 6 pair of gloves, right? Get my sanitizer there. Everything's there. My gauze is ready so that I don't have to fumble around in my bag, look for this, take my gloves off because I touched something dirty and then reapply. So get yourself set up so that you don't have to do that, okay? Also, this is a good one because when you're out in the field and with your patients, cutting supplies for multiple uses is okay with clean technique. You just need to make sure you're taking the precaution to protect it. So if that's like taping the package in a way that it can try to stay as clean as possible, putting it in those Ziploc bags that we talked about, all of those things are appropriate and part of clean technique, okay? And then you can use tap water. No, so we're talking about like if you're educating your patient, or like say for instance, I'm somewhere at a shelter and I don't have any saline, I will go to the tap and take in a clean cup and use tap water. Oh, I wish we did like a little well, right? You're like, how you doing that? What y'all got going on in Philly, right? Y'all can just get water off the street? No.
Okay, so in that instance, then are y'all taking out?
We do. We take out saline, cleansing products. We take out Vash, which is a great cleanser for like really dirty wounds. Yeah.
I was just going to reiterate that like
like there's really good evidence on the like that tap water is just as good as
Yes.
saline, sterile water for cleaning wounds, and those studies also use the same volume of the like whatever they're using. So if you think about the amount of tap water that you can get into a wound versus like a little small splash of something,
Right.
it's even better than
Yes.
that. So I even prefer in the hospital, I prefer tap water, and I have a patient like run their wound under the sink.
Wash their hands, right?
instead of-
Hand wound, arm wound.
Yeah, instead
wash
of washing it out myself.
Yep. Okay. So self-care, some of the stuff we already talked about, easy peasy stuff. Patients don't clean with the cytotoxic stuff, leave the iodine, the alcohol, the bleach, right? We talked about this already. Saline, bottled water, soap and water, or tap water is fine, right? Cleaning hands with sanitizer or soap and water before and after wound care. This is for like patients if they don't have gloves. I feel like a lot of times for patients, gloves can be really cumbersome. So if they can sanitize their hands in between, as long as they're not terribly soiled or the wound isn't draining like crazy, I think it's okay for them to use their hands as long as they really know how to get them clean. And then wounds need to be clean and covered. No air. For those of you yesterday, we're not letting the air get to it. Our grandmothers told us that. They were wrong. We're not doing that. Grandma, you were wrong. Avoid overly constricting wraps. We talked about that yesterday with Cohen. Avoid injecting into the wound whenever possible. I always tell my patients, I know you're going to do what you got to do, but if you might just try to find somewhere else or just decrease a little bit. And then the picking. I mean, how many amount of times I have to pop people's hands a little bit. Like, come on, what are you doing? Stop picking that. I can't help it, it's a scab. I need to pick it off. You don't. Like, leave it be, please. They have the fingernails and it's just, ugh. Okay, so wound assessment, right? This is the foundation. You can't make a plan unless you assess the wound, okay? A good plan, unless you're doing the assessment. Foundation of treatment, of the treatment plan, we've got maybe like 20 minutes to break, so. Holistic, right? You need to review the chronic conditions, medication, nutritional status, and overall health of the patient. That's going to really help you determine how aggressive you need to be. Also, when we're talking about debriding type, picking a type of debridement, really important to understand your host and their healing ability when you're making a plan. So assessing that ahead of time is going to help you develop different goals, as well as for you to look for different signs and symptoms more quickly in someone else that you might not in another person. And then you want to conduct this at regular intervals. So if you measure it in the beginning, which sometimes people do, and then you never measure it again, that's not really helpful, right? So whatever that interval is, I'm not going to tell you, like, you know, of course in school we learned it should be like weekly or bi-weekly, right? I'm not going to tell you how often to do that. I feel like in this population, it's going to depend on the setting. I personally try to, because I'm usually doing a wound eval whenever I see people. So for me, unless I saw the person earlier in the week, I'm always measuring the wounds when I'm doing a visit, because it really helps me to understand where we are with things. Very hard for me to gauge healing and like, it's moving kind of slow, or we may need to step it up if I don't know what the measurements are, okay? And then we always need to make sure we have enough light. So there's plenty of times where, you know, I'm doing something and then I'm like, oh my God, I can't hardly see. And then I have somebody shine a light on and I'm like, wow, okay, there we go, let's do it. So light and equipment, we talked about the cyclone, protecting your back, okay? We want to continue to do this work without causing disability, right? And then so wound assessment, particular HPI, you need to know when it started, their history of similar wounds. Some of this we went through yesterday, I feel like. Current and prior treatment and the outcomes. Who's caring for the wound? When was the dressing last changed? That'll help you. Knowing when the dressing was last changed is a good one because it'll help you determine how much it's draining, right? You'll be able to kind of quantify it a little bit better if you know how long a dressing has been on there, right? If it's been on there for a day and it's completely soaking through, you're like, oh, wow, this is draining a lot. Or they put it on earlier that morning and it's soaked. Okay, that's draining a lot. Or if they say like, oh, I put it on 3 days ago. And you're like, oh, okay, well, it's not that much, right? And then, of course, we talked about this a lot, patient treatment preferences. So anatomic location, size, we'll talk about how wounds are standardly measured a lot of times. Peri-wound skin appearance, because it'll tell you a lot about infection. Bacteria will tell you a lot about whether the dressing is too dry or traumatic to the surrounding skin, or you need something to absorb moisture, right? It'll help you with that. Presence of wound odor after cleansing, really important to assess the wound after you cleanse it. I've not smelled too many wounds that don't have an odor when I'm taking the dressing off, right? Some of the dressing materials, in particular hydrocolloids, really cause a really funky odor when you take them off, and that's just normal. It's not, doesn't mean anything. And then the amount of exudate or the drainage, right? And then describing the appearance of the tissue in the wound bed and pain. We need to be assessing our patient's pain so that we can adequately address that when we're picking a wound care regimen. Some people, depending on, we just actually had a patient a couple months ago. And the regimen that I chose for him, when I say it was working, it was actually the one picture that I showed y'all, and I did one treatment, and then in 5 days, it was like, woo. And I was like, man, this is great. But it was burning him. He wasn't tolerating it. And he was trying, I feel like in the beginning, to be like, yeah, it burns a little bit. But it's working, I'm gonna stick with it. And so we need to be assessing the pain to make sure that the dressings that we are using aren't causing additional pain. And while that dressing was working really well, and he was like, no, just go ahead, put it on, I discontinued it because I said that you're not supposed to be having that much pain with any type of dressing. So it was not appropriate for him. All right, so wound classifications. Here's some ways to classify them. I usually use the first two the most, right? So partial thickness wounds, and these two, I like them because you can use them for any wound, right? A little bit later, I can't think which wounds I put in here to talk about. We have a very ambitious schedule here. I'm not sure what I was thinking. But we'll talk a little bit more about like staging, like pressure ulcers are staged, diabetic foot ulcers are staged. But even with that, these two things you can use for any wound. You cannot stage anything other with a pressure ulcer scale other than pressure ulcers, and you can't use the Wagner scale, which is for diabetic foot ulcers, for anything else. But partial thickness and full thickness you can use, okay? So it's skin damage into the epidermis and or dermis, right? So we saw our skin, so that's the first two layers of the skin. Then full thickness is skin damage through the dermis to the underlying structures. So once you start seeing slough, what do you think is partial thickness or full thickness? Exactly. There is no fat in the epidermis and the dermis. Slough is dead fat. So if you see slough, it's full thickness, okay? So those are the ways that I use most frequently. Then there are other ways you can say, like a deep wet wound. And I think these are cool if, I feel like especially when you're starting out, you might not really know what partial and full thickness is. I like those two though, because it really helps people to understand where the skin damage is, right? So deep wet wounds are wounds that have depth, tunnels, undermining, and we'll talk about those more. With moderate to large amounts of exudate. Deep and dry are wounds that are deep with tunnels, but they don't really drain a lot. And then we have shallow and wet. And then they're shallow, there's no tunnels, there's no undermining, but they're really draining a lot, which I feel like venous ulcers kind of fall into that category. They're usually pretty shallow, but they're very juicy. And then shallow and dry, right, would be more like, I feel like arterial ulcers are relatively shallow and they're usually pretty dry. One other thing I want to talk about a little bit, because I just can't remember what I put in this presentation. The partial and full thickness, please try to make sure you're identifying the structures in the wound. It has nothing to do with depth. That's why I like the two, because you can have a full thickness ulcer that's looks very superficial. Like if I get a wound on the bridge of my nose, the bone's right there. So it can be full thickness even though it's very shallow, okay? And we have some pictures so you can kind of see, we can talk about that a little bit more. Now, all right, we got about 10 minutes. All right, so we're gonna start this a little bit and then we'll pick back up, okay? So measuring, right? I feel like for the most part, from what I've seen and from like ordering supplies, as we know, I feel like in insurance and with getting insurance to cover supplies, etc., Medicare is king. So whatever they say, most of the other payers, I feel like, follow behind that. So with that in mind, I feel like whenever I'm ordering supplies, they want to know the length, the width, and the depth, right? So I usually do default to using that, but there are like some wound care centers do like surface area measurements, which can be a little bit better to assess healing because, if the surface area may change, but the measurements in the length and the depth, like sometimes you might have a wound where it's 4 by 2 by 0.2, but then the next time it's 2 by 4. You know what I mean? So you're thinking about it, but surface area really kind of can tell you in general overall if the wound is making progress versus you assessing wound healing versus each individual measurement, right? So I generally use length, width, and depth. I feel like those of us who worked in home care and had to worry about doing an OASIS. Anybody in here used to work in home care? And doing the OASIS, you had to do length, width, and depth, and length being head to toe, no matter what that was. So for me, I always do that. Like even if it's like a C-section incision, the length is like 0.2, okay? But there are some places that do length as the longest measurement and then width, which is perpendicular to that, okay? And your depth is always gonna be the depth that's the deepest. So you kind of have to probe around a little bit. You can't just look at where you think it might be deep. You need to take the Q-tip a little bit to see where it's deepest because you can sometimes find different tunnels in sinus tracts, okay, that need to be filled. All right. I didn't do nothing. Oh, is it just like, okay, I need to just rub it. Okay. Open sesame. Okay. So tunneling and sinus tracts. I love this picture because this is both. Tunneling, sinus tracts, the Q-tip or the path of destruction is in one single direction from the edge of the wound, right? So if you can just put the Q-tip in and go one way, that will be a tunnel. And I need to walk around a little bit. Oh, yeah. Please. Do the thing. Sorry. I'm not this formal. I'm not really this formal. I usually like to walk around and stuff. So this is easy, right? This is the tunnel going straight down in that area. This here is a sinus tract. So it's an opening in one direction, but it's a path of destruction in one direction, but there's two openings, okay? So that's how you would define it. And for this, you'd measure the distance here so that you know what the sinus tract is. And then for tunnels, you're gonna note the depth. So you stick the Q-tip down, and then I would hold my finger right here and pull out. And then I would take a measuring stick and look to see how long that area is. And then I would document that. Then you document it using the direction of the face of the clock, with 12 o'clock being up towards the head. So an example is 2 centimeters, a 2 centimeter tunnel at 6 o'clock, right? I'm gonna bring this too. And then undermining, right? Along the periphery of the wound. So if you take a Q-tip and stick it in a wound and you can move in any other direction, that is undermining, okay? It's along the periphery of the wound, and it's documented using the location of the deepest depth and the direction using the clock face. So up to 2.5 centimeters of undermining from 10 o'clock, excuse me, from 10 o'clock to, say 12 o'clock, right? So that it starts at 10, it goes up to 12, and sometimes what I will do is the deepest is at 12. So I might tell you that there's undermining from 10 to 12 or 10 to 2, and then I will also say deepest at 1 o'clock. So whoever is following me knows where to look for that deep tunnel to assess the status of it, healing, and also so they won't miss it, because when you're doing dressings, any dead space, like undermining, tunneling, deep wounds, it needs to be filled, okay? All right, so wound assessment and wound bed descriptions, we'll do this, and then when we come back, we'll look at some examples. So granulation tissue is bright red, beefy, right? I hate to say that, but it is. It really is beefy. Beefy, red, granular, looks kind of bumpy. And we'll talk a little bit about granulation tissue that's healthy and some examples of granulation tissue that let you know that the wound is in a chronic state and there's lots of bacteria in the wound bed, or what some people say is like a high bacterial bioburden. And then slough is usually stringy, mucoid. It can be yellow, it can be tan, sometimes it can be gray. And you want to note the color, the consistency, and the adherence to the wound. So if it's really stuck on there and you can't move it, you would say firmly adherent yellow slough. If it's jiggling all around, you say loosely adherent, to give someone an idea of what we're dealing with here, okay? Then Eschar is black, gray, brown. It can be loosely adherent or firmly adherent. Eschar in general, I feel like there's usually a portion of it that's very hard and dry, which is different than slough. Is a lot more stringy and mucoid. And I do have some pictures of that. And then there's pink and red and smooth, right? Which is not bad. There's no slough, there's no Eschar, but it's not granulation tissue. And that also tells you some things about where you are in the stages of wound healing. And then epithelial tissue, pink and dry, which we have pictures of that. And especially in people of color, people can often mistake epithelial tissue as an open wound because it's a different color than the person's skin. And that's normal in people of color because the melanin has to regenerate in that area, and sometimes it might not, okay? So I have a couple pictures, and we'll talk about that. You're gonna quantify the amount in the wound by percentage. Now, also, this is all in a very ideal world. I do not expect everybody to leave here today and to go and have these really robust wound descriptions. It takes time, it takes practice. They actually had done a study many years ago now, and we used to talk about it at the wound care conferences. When they looked at wound care professionals who were trained, our percentage quantifications were really close, like within maybe like 5 to like 8% difference. So once you start to do it for a while, you really get good at it. Most of the time you'll like look at the wound and you'll look at it as a whole, split it into 4, and that's an easy way for you to try to break it down to figure out how much tissue of a specific tissue is taking up the wound. Now I'm gonna stop because we have some pictures and I wanna get into that a little bit more. We have a break. I just wanna take any questions if any have, yep.
So this is just kind of a really practical question about cleaning the wounds. I feel like a lot of times, especially when it's really cold out and people are wearing a ton of layers, if someone has a wound like on their lower leg, they're happy to pull up their pants to let me look at it, but they don't want to take off their socks and shoes. And you know, I find that chucks are really helpful, like you can tuck them into the socks or like put them below them. But do you have any tips or tricks about how to like really irrigate a wound, really like clean it well without getting them soaked?
No. No, I mean, I really don't. And I'm like super real with my patients. And I like tell them, I need you to, if it's super cold, I'm not gonna make somebody strip down. But being honest, the amount of irrigation that I may be able to do is gonna be limited. I'm not gonna irrigate someone's wound with a whole bunch of fluid and then their sock is gonna freeze. I'm not gonna do that. Or their sock is gonna be wet and then they're gonna have trench foot. So I might just opt to soak a gauze pad and like lay it on there for a while. I might just opt to like kind of shake it and wipe it because I mean at the end of the day, what we should do, I feel like a lot of us are clinicians in here, we know that that's not always practical, right? So I would not just soak somebody. Now in the summertime, I don't know, maybe. But I usually tell them like, you need to take your shoes off. Like I even have people in the office that'll be like, oh, I don't feel like doing all of that. And it's like, listen, you want to come in here and you want me to get you together or you want me to just like patch you up? And like sometimes they might just want a little quick cover so they can get out on the road and I'll do that. But don't come in here talking about something, I think we need some different dressings, it's not really working. And then I say, all right, let me take a look. Oh man, I don't feel like taking all that stuff off. All right, well next time. Because I'm not going to change the plan of care without really being able to do a full assessment. And that is because there are plenty of times that I've tried to do what the patient wants me to do. This is when we talk about ethics. And I've missed something. And so I don't do that. I'm not changing the plan of care if I can't fully assess where the wound is. It's really just not the right thing to do. Okay?
Yeah, I guess just two things. One, on that front, skinny jeans are like the bane of my existence.
Oh my God. Skinny jeans and like tights.
Yeah. So I don't know if you have any great strategies for that, especially in the winter. But then my other question was, just with like the picking and the nails, I don't know if nail care is like a regular part of your wound care plan, but that is something I'm thinking of making like one person does the nail care, one person does the wound care.
I mean, I have not done it myself, but I have really had people come in and like not even just nail care. I had one patient and he would just come in and he's coming for a visit and he wants like me to do the wound care. And when I just say he's just a mess, like he's just, because of the circumstances, he's just not clean. There's drainage everywhere. There's blood everywhere. And luckily where I work in clinic, there's a shower. And like sometimes I'm like, listen, you gotta go get a shower before we can kind of get started. Like I can't check you out like this. I'm gonna need you to get freshened up. So there are times where if someone's got like wounds and stuff on their hands and I'm like, you need to wash your hands in the sink so we can like start from scratch here. And then I have a conversation with the person about like trying to get them to understand, especially with the picking, how much bacteria is underneath their nails. I mean, it is insane how much bacteria we store underneath our nails. I mean, just forget about it. Then you put artificial nails on there. I mean, my goodness. So I do encourage that. I can't say that I spend a lot of time on nail care, but I do think that that's a really excellent point to consider. You know, if you can, you know what I mean? I feel like we are usually out alone too, so we have to balance what we can do in that one encounter, because our visits are like short bursts of like care, right? Yeah, I see some other hands. It takes a little time.
Oh, hey, sorry. The skinny jean thing, I feel you. The hipsters have destroyed it all. Sorry if you're a hipster. So I think that we if you're able to get into like a bathroom or anywhere with a kind of, I mean, just having them pull down their pants is always like the best possible thing, and giving someone a chuck for some privacy just to put over their lap is good. We don't always have the opportunity to do that, but if you are somewhere where you're able to do that, then I'm just like, we just need to pull down your pants. So sometimes I've like pulled people into our SUV, or I've pulled them into a bathroom where I don't think we're going to get kicked out of, or something like that. So that would be like probably like the only way to do it.
I was just going to go a little utopic and futuristic, because I did live once in a world in America where in a wound care center where they are using these wound care apps.
Yeah.
So you can take a picture.
Oh, yeah.
And it's an app you download. It's got the picture. It's got and then you could see the progress of a wound. And there's in New Orleans a couple opportunities that we're moving toward where people are throwing money around.
Nice.
And so this thought of like, I was thinking of it as a communication between the people on the boots on the ground and a wound care center to say, hey, this was, this guy doesn't want to come in, or whatever the circumstance is. But what do y'all think about wound care apps and more
like a
accurate
telehealth
picture?
type of
Yeah. Well, it
access.
actually, I don't know if you've seen them, but they actually take a picture of the wound, and it does all the measuring, and it's got the
I have
scale
seen
and
them.
all that on it.
They're very
and-
expensive.
Yeah, they're very expensive, but they're really cool because it takes the subjectivity out of what
Yes.
someone else saw, and it puts the date on it and everything. And like you said, it's in a well-lit setting. But is that something you would dream of or
Absolutely.
recommend? Or okay.
I would dream of that, and I'll say this too about pictures. I do not take a lot of pictures, if that's surprising to you all, because I'm like just in it while I'm doing the work. But also, I don't generally upload pictures that I take into the computer system, and I'll tell you why. Unless wound photography is tricky. There's a lot of little legalities there, right? Generally, if you're going to do them, there's like whole wound picture protocols a lot of times for wound care centers. You need to have a particular camera. You need to have it from a certain distance. There needs to be this amount of light, et cetera, et cetera. And as you know, in our settings, those things change all the time. Person's not going to be able to sit the same way. I'm not going to be able to stand up, stand back, or get the picture at a different distance depending on where I am. If I'm like right at the foot of someone's tent, I'm not going to be able to move forward and back up but so much. Or even if you're in a tent, you're not going to be able to like back up and move to the right and all of those things. So I usually don't use them in the chart, because what a picture looks like can be very different from what it looks like in your face. And so you get into this situation where you took a picture, but you saw it. And then the care you did was off of what you saw. But then say, God forbid, there's a court case and they look at the picture and they're like, well, this looks like it's infected over here and this and this and that. So there's a way for them to kind of pick things apart. It's really hard to standardize picture taking, I feel like, in the field. I do think that there is a place for wound telehealth, but I feel like in those instances where you're using an app, or there's a two-way system where there's a specific a phone or camera that you're using with the other provider. And I feel like some of the newer companies that are doing wound care for telehealth, like with nursing homes and like in rural places where there aren't a lot of wound care providers, they are utilizing those, but it's very standardized.
Sorry, I know we're trying to get to break. I just wanted, Lyd, if you could follow up, can you just briefly talk about what we learned about in our practice from like other people asking if they need antibiotics on the phone from sending you pictures of
I do
wounds?
not prescribe antibiotics from pictures. Especially if there isn't another clinician there that can tell me specific details of the wound. I have patients all the time that's like, look at this, I need it, it's red, it's pus, give me the medicine. I do not do that. I need to see it. I need to feel it. I need to also, and this is what I try to explain to my patients too, I need to see you, right? I need to see you, because what if I look at just the picture and I give you antibiotics, but you look terrible and you're possibly septic, right? So here I am giving you oral antibiotics and I need to be telling you to go to the hospital. So I do not prescribe antibiotics from pictures. I do not. Yeah.
So we have something, we're in Minneapolis, and we have something called an e-consult that's really worked well for our clinic. And so just one patient in particular who will not go to like wound care or to primary care. And we have both outreach and clinics. And so, and he's been coming to us for like 20 years and just has, you know, lower extremity wounds and ulcers and things like that. And he kind of walks in, takes 3 hours to get there on a bus, and he just prefers to come to healthcare for the homeless. And he actually has a little, we think, house somewhere. But at any rate, we've been dealing with wounds for a long time, and even though it's not ideal to send a picture, this e-consult is amazing. And we can actually do it with all specialties, and I'm more saying this if this is something you can work out with your health systems
Yeah,
for
sounds
other
great.
specialties as well. So with a picture and description and send it, a couple times he came with maggots, and he doesn't come that much, and so we were just like, okay, what is the next step, and how do we do this with maggots? And they were really helpful. So anyway, that's just a plug for e-consults along all specialties.
Yeah.
We found it like really helpful.
And it can be really great for wounds. I would love if we had more of a connection in our area with the local wound centers. I've been doing wound care for a long time, but most of my wound care experience is in home care. And you just don't have access to some of the like more advanced modalities of wound care out of the hospital in a wound clinic setting. So I would love to be able to partner with a wound clinic to be able to, and like I said, that's like where you have a clinician on the other side who can say like, well, yeah, this is what the wound looks like, but there's no warmth around it, there's no induration, the patient is stable, blah, 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 so that all of that other information is available to you and you actually have some eyes on them that's experienced to say, yeah, they look okay. So yeah, I think it could be very helpful. I want y'all to be able to get coffee and stuff. It's 10:38.
So, yeah, we're going to come back. We're going to take 15 minutes for a break. So we'll come back at, about at 5 of. We're going to get started again.